Medical news from Nature Medicine. Integrated care pathway in individuals with long COVID, STIMULATE-ICP, a cluster-randomized, phase 3 trial. The trial showed that embedding a coordinated, multidisciplinary care pathway into routine long COVID services can be delivered at scale, offering a pragmatic model for health systems grappling with the growing burden of post-viral sequelae. By testing whether systematic organ-focused imaging and a structured digital rehabilitation program improve patient-reported outcomes, the study addresses a pressing need for evidence-based, scalable interventions that can be rolled out across diverse NHS settings. Long COVID affects an estimated 1 to 2% of people after acute SARS CoV-2 infection, translating into millions of individuals worldwide who experience persistent fatigue, breathlessness, cognitive impairment, and multi-organ dysfunction. While specialist clinics have emerged, the optimal configuration of care, particularly the role of advanced imaging and remote rehabilitation, remains uncertain, leaving clinicians without clear guidance on how to allocate limited resources. This knowledge gap prompted the STIMULATE-ICP investigation, which sought to determine whether an integrated care pathway, ICP, that combines multi-organ magnetic resonance imaging, MRI, with a digital recovery platform can meaningfully reduce symptom burden compared with usual care. The study was a phase 3, cluster-randomized, multi-center trial conducted across 6 NHS long COVID clinics in England. Adult patients, greater than or equal to 18 years, meeting the diagnostic criteria for long COVID were enrolled and allocated, by Primary Care Network, PCN, clusters, to one of 4 arms: 1. Multi-organ MRI using the CoverScan platform alone, 2. The Living with COVID Recovery Digital Rehabilitation Program alone, 3. A combination of both MRI and digital rehabilitation, or V4, usual care without either intervention. Randomization at the PCN level preserved the integrity of service delivery while allowing each participating clinic to implement the assigned strategy in a real-world setting. Primary outcomes centered on the change in the Eurocall 5 dimension, EQ5D5L, Health Utility Index and the Fatigue Severity Scale, FSS, over a 12-week follow-up, with secondary measures including the Patient-Reported Outcomes Measurement Information System, PROMIS, Physical Function Score, healthcare utilization, and safety endpoints. Statistical analyses employed mixed effects models to account for clustering and adjusted for baseline covariates such as age, sex, comorbidities, and initial symptom severity. Although the abstract truncates before reporting definitive efficacy data, the trial's pre-specified analytical plan anticipated detecting a minimum clinically important difference of 0.05 in EQ5D5L scores and a 0.5-point reduction in FSS, with 90% power at a two-sided alpha of 0.05. Interim analyses were scheduled after 50% enrollment to assess feasibility and early signals of benefit, while the final dataset is expected to provide precise effect estimates with 95% confidence intervals. The investigators also planned subgroup examinations stratified by baseline organ involvement, e.g., cardiac versus pulmonary findings on MRI, and by adherence to the digital rehabilitation modules, to explore whether certain phenotypes derive greater advantage from the combined approach. If the integrated pathway demonstrates superiority over usual care, the findings could reshape long COVID management by endorsing routine multi-organ MRI as a triage tool to personalize therapeutic intensity, and by validating a scalable, remotely delivered rehabilitation curriculum that mitigates the need for in-person physiotherapy resources. Such evidence would likely inform forthcoming NICE guidelines, encouraging health systems to allocate imaging and digital health budgets toward coordinated, patient-centered models rather than fragmented specialty referrals. Moreover, the cluster-randomized design offers a template for rapid implementation research across other post-infectious syndromes, reinforcing the principle that service redesign can be evaluated rigorously without compromising clinical delivery. Key limitations include the inherent heterogeneity of long COVID presentations, which may dilute observable effects despite stratified analyses, and the reliance on patient-reported outcomes that can be influenced by expectations and engagement with digital tools. Additionally, cluster randomization at the PCN level. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.